are joining us remotely and those who are here with us today. Excuse me for being a little awkward as the technology interrupts my beautiful train of thought. Anyhow, we talked a little bit about the upcoming institute, which is fantastic. I don't want to take any more of our time today. I'm delighted to introduce our keynote speaker, my colleague, Amaya Perez-Brumer. Amaya is an assistant professor in the Division of Social and Behavioral Health Sciences at the Dallin Lana School of Public Health here at the University of Toronto. She's got a few other wonderful credits to her name, and she told me I shouldn't read them all, but I am going to read some of them. Amaya is also the CIHR Canada Research Chair in Global Health Intervention Justice, and so we're going to hear a little bit about that today. She's a fellow at the Center for Critical Qualitative Health Research, so that basically means she's a really top-notch qualitative researcher, right? And she is also a faculty fellow and affiliated at the Women and Gender Studies Institute and Department of Anthropology at University of Toronto. So just a few more interesting facts about our keynote speaker. She earned her PhD in socio-medical sciences from Columbia, and she has a Master's of Science in Social and Behavioral Sciences from Harvard. She integrates social science theory with innovative mixed methodological approaches to improve HIV prevention, intervention, implementation, and acceptability among people of diverse genders and sexualities across the globe. And we're going to hear about that today. So those of you who had a chance to read the article that Amaya sent around have a sense of what she'll be talking about. It is a little further removed from specifically policy perspectives than most of our talks have been, but I know that Amaya is really interested in policy implications of what she does, and I'm sure that Amaya will draw them out. And that will be also the role of our discussants, who today are Pamela Kaufman, as I mentioned, and Reagan Sapphire. So Pam Kaufman is a close colleague of mine. I've introduced her here in this in the rounds before because she gave a beautiful rounds talk in the fall. Pam is an assistant professor, also in social and behavioral health sciences. She's a close colleague of mine at the Ontario Tobacco Research Unit. Her background training is partially in landscape architecture, and she's done a great deal of work on secondhand exposure to tobacco and also now cannabis smoke. Also the aerosol, not the vapor, the aerosol that comes from using e-cigarettes. So welcome, Pam, and I explained that you are joining us at the last minute and therefore you are remote today. And our student, our trainee discussant is your colleague, Reagan Sapphire. Reagan is not only in this collaborative specialization, but she's also in the collaborative specialization in addictions studies. She is a student in the School of Social Work. She's doing her master's degree and is specializing in the mental health and health stream. Between her bachelor's work in social work, which was from Memorial University in Newfoundland, Reagan worked in direct practice roles, developing harm reduction and overdose prevention programs alongside folks with lived and living experience with drug use in Halifax, Nova Scotia. Most recently, Reagan worked as a school-based social worker, supervising a team of student support staff working between 6 schools in rural Nova Scotia. So welcome from the Maritimes to the big city. It's great having you as part of the program, and thank you for coming today. So this is where I step out and you step in, step up to the podium here. I think we need to minimize this.
I'm actually just going to turn off the video. Because or not, whatever.
You good?
Yep,
Okay.
good. Okay, so I'm taking off my mask. Hopefully that will help with hearing of the presentation. I'm delighted to be here. I know some of you in this room, and hopefully after this meeting, presentation, whatever, I'll get to meet some other of you. I apologize in advance for those who may have heard variations of this talk. Carly, this was a keynote at the Canadian Conference on Global Health, but it's an expanded version. So yeah, I'm delighted to be here with you all today. Okay, so as Rob mentioned, I'm an assistant professor in SPHS. I'm located on the 5th floor if you ever want to say hi. Today, I will be asking you to join me in thinking through who benefits from global health prevention science. And in doing so, the larger question that I'm asking you to think through is, does global health make health, or does global health make data? This talk is centered on the politics of HIV science globally, and the key lessons that I've been taught by Peruvian trans women that I've had the pleasure and the privilege of working with for over a decade. So there's a few things that I just want to do as a preamble before we go into the talk. One is oftentimes when I give this talk, people are like, wow, shit's bad in global health. And I want to just put that out from the front to say, like, let's take this out of global health and talk about any targeted health research. So anytime we're talking about key populations, most at risk, any kind of stratified research, these are the questions we need to talk about, specifically the issues of benefits. Okay, so before I go into my land acknowledgement, there's another piece that I want to acknowledge. This work that I'm presenting today is based in Peru. There is extreme geopolitical turmoil in Peru right now, which is not quite making the media in the way that it should, probably because of the state of the world. But so it needs to be flagged because too often we don't talk about research. Sometimes we talk about research in post-conflict settings, but we don't really talk about research in ongoing conflict settings. So what I want to say is that there are ongoing deadly demonstrations happening daily for the past 3 weeks. These demonstrations are demanding for the dissolution of Congress, the resignation of Bularte, who is the first female president of Peru. Some people are calling her more of a dictator than a president, and for a new constitution. And there are many, many protests ongoing. Again, these are deadly. And the other thing that needs to be underscored, and something that I'm not quite seeing coming out in the global North media, is how these protests have been led by indigenous communities, namely in the Andes, and the disproportionate violence faced by indigenous communities in Peru today. So that is a little preamble before we go into the land acknowledgement. And so this talk is given in Toronto, a Haudenosaunee word known in English as Toronto. Toronto consists of ceded land covered under Treaty 13, as well as unceded land, and that continues to be contested. I would like to acknowledge the traditional territories of the Mississauga of the New Credit First Nation, the Anishinaabe, Wendat, Huron, and the Haudenosaunee Indigenous people on which the University of Toronto now stands. I also recognize that as a settler living on stolen land, I benefit daily from ongoing violences and legacies of colonialism. I have an ongoing responsibility to learn about the land that I'm living on, to cede power to Indigenous people, and to amplify ongoing projects of Indigenous resurgence and sovereignty. Okay, so again, a bit more of the intro stuff. So I'm Venezuelan, American, and now after 5 years in Toronto, a Canadian permanent resident. Spanish is my first language, and I identify as Latina. It is telling that I'm afforded the honor to be here with you today. I'm a cisgender woman, and I do not take lightly the privilege of being here. And I must underscore that this talk today and my scholarship, all of it, is indebted to my Peruvian teachers who push me daily to recognize and grapple with the extreme privilege and power at the center of who gets to do global health research. So this is the question, like, who does get to do global health research? As an HIV prevention researcher, my work centers on the making and the analyzing of data to improve HIV prevention efforts. So what do I mean by that? Currently, I have a CIHR primarily epi study in Peru looking at HIV and STBBI prevalence among Venezuelan migrants, right? So this is analyzing the data to improve HIV prevention efforts. And as a social theorist, because as many of us in this room know, we wear multiple hats, especially interdisciplinary scholars, I study the analyzing of the making of the data. And so key to this is who gets to do health research and who are its beneficiaries. Specifically, I study the ways in which power, sexuality, and gender are entangled with contemporary approaches to HIV science. On this slide, you'll see a photo of various members of Feminas, a community-based organization in Lima. The text is very small, but underneath the photo it reads, Peruvian transgender women say they want more leadership roles in studies involving them as subjects. I want to be clear that politics and power are central to this talk, and thus I want to draw your attention to the word subject. What might it mean to be a subject of HIV research? How does research act as a form of discipline and/or social control? Learning from trans women in Peru, where I've been conducting research since 2009, this talk is meant to be a provocation. And I ask you to join me in reflecting on our own social location, our own privilege, and most importantly, our responsibility as researchers. So there are great upheavals in global health. We have activists globally to thank for ongoing demands for change and to reimagine a more just future. Thank you to those who name and evidence the ongoing work of colonialism, white supremacy, capitalism, and violence, and the work these forces do to uphold the power and privilege of a few, like myself, who do global health research and earn a living doing so. We as scholars and practitioners of global health have work to do. There's simply too much at stake. Research globally. I ask you to join me in sitting with the discomfort, and this should be a discomfort, of the following questions. Does HIV research make health, or does HIV research make data? How can we ensure that science and knowledge translate into tangible health gains? So let me tell you a bit more as to why I ask these questions and why I believe these questions get us to the heart of extractive logics in global health. So first, we need to consider big shifts in HIV science that have fostered new data. The fourth decade of HIV and AIDS has ushered in a new era of how and what type of research on the virus is conducted, with an explicit focus on pharmaceutical-based prevention and new technologies at play. The advent of pre-exposure prophylaxis, or PrEP, is a remarkable innovation to prevent HIV acquisition. And yet, its development has led to a boom in research among populations classified as most at risk, classified as key populations, and thus in most of need of PrEP. People classified as men who have sex with men, often the acronym uses MSM, and especially transgender women, have been central in this focus globally. The shift to prevention and emphasis on certain groups necessitates a rethinking of the politics of data extracted from people of diverse genders and sexualities in the pursuit of HIV prevention. So, for my career, I have and continue to work on HIV prevention for communities at heightened vulnerability to HIV. Peru has been central to the testing of HIV prevention strategies. Take, for example, the fact that Peru contributed more than 50% of the global sample for the watershed IPREX study that sparked significant changes both for global policy and associated scientific actions to support PrEP for HIV. So when I say global policies, I mean WHO recommendations, FDA approval, CDC approval. Yet today, more than a decade after IPREX, the evidence continues to reflect a burden of HIV among the very communities, namely gender and sexual minorities, that participated in and supported in the advancement of this prevention knowledge. The question is why? There is a need to examine how HIV biomedical prevention incorporates contradictory practices that can perpetuate existing inequalities. So this needs to be stated in a different way. When I first started working in Peru, available convenience samples evidenced that HIV prevalence among trans communities was around 30%. Last month, our own study with young trans women aged 18 to 24 evidenced that every 2 out of 5 women who participated in our study, or 40%, were living with HIV. These are new HIV diagnoses. This is shocking. Since 2009, I've been involved in numerous studies targeting this population with total funding above 10 million USD. So my question is, what the hell is going on? Obviously, there's a lot going on and a lot to account for. Yes, I've been pushed to think about the limits of this example. These are convenience samples, not the same population. What about COVID-19 effects? But to me, these questions are irrelevant when faced with this dire reality that every 2 out of 5 women in our current study are currently living with HIV. So to seriously start disrupting how global health operates and understand what needs to be changed, I want to share with you 3 lessons that I have learned from Peruvian trans women. Okay, lesson 1. Why more research but not more health underscores this discordance between the increased frequency of PrEP research targeting trans women in Peru and the limited actual improvements in HIV outcomes among trans women. The trans women who shared their experiences participating in HIV prevention research often described the choice to participate in these studies as complicated by the limited HIV prevention and care options for trans women within the existing healthcare system. Yet even those who noted the importance of HIV research for access to care were wary of the surge of clinical trials and noted that the health impact for trans women was limited. Care was often described as ephemeral and HIV acquisition posited as inevitable. 27-year-old Donica, which is in the yellow-orange, told us, "I participate in studies now so that I can get care. But what happens once I get sick? These studies end." While many participants said they valued the care provided by studies, they also questioned the lack of long-term health benefits for trans women. And this was further complicated by the wariness of foreign investigators, perceived to be driving the PrEP research agenda. For example, another participant, Maria, noted, "How long have gringos been researching us? Why are we still getting sick? And what will I do if I get HIV?" The second lesson centers on reframing research processes as a research marketplace, underscoring the political economy through which global health data are produced and circulate. I want to just pause here for a moment. Literature has underscored the research marketplace of HIV science. Oftentimes in social science literature, it's referred to as the HIV industry. Very few people are talking about the political economy of academia and how those political economies are entangled. And so that's really what I want to start drawing your attention to. So this second lesson centers on the reframing of research processes as a research marketplace, underscoring the political economy through which global health data are produced and circulate. For example, while observing operations of an ongoing HIV prevention study, MITE in yellow, a peer recruiter and study staff commented, quote, "Several of the travesti are coming in and don't understand the word transgender, and they don't identify as transgender. This has become a problem on the surveys since they are leaving this question blank. And Dr. Smith has emailed me twice now about missing data on the interviews, or on the surveys, excuse me." To this, the leader Yasmin Pink responded, "Tell them that travesti is the same thing as transgender, and the surveys were written by gringos. Plus, if she wants to continue in the study, continue getting prep, and continue getting money, she needs to fill out the survey completely." This interaction demonstrates the politics implicated in creating data that meets the needs of this broader research economy, the active practices of minimizing missing data for quality exportation. This example also highlights the uncomfortable tension between gringo-designed research that lacks contextual relevance. Travesti is a term to describe trans feminine identities that is closely associated with street-based sex work and often reflects a lower class within the Peruvian context. So, is travesti really the same thing as transgender? And if not, why say it is? This example leads us to question not only the value of the data collected itself, but the coercive nature of the practice and the process of data collection. The third lesson highlights the contradiction that PrEP, as a key HIV prevention technology, has been tested repeatedly on trans women, but is not readily available to them, furthering the belief that their community is not actually PrEP's intended users. As noted in a formative focus group, one participant told us, "Why are we, trans women, being used like guinea pigs, every single one of us?" This disjuncture was further amplified by the conflict between short-term rewards, meaning financial incentives, temporary access to new medications, against the long-term public health failures, leading to limited access for successful therapies and care. As described by another participant, Angelica in the green turquoise, "What can I tell you? Do I have a problem that my community is treated like an experiment? Yes, but we continue to participate and work on these studies because we are seen. We at least get some HIV care. Sometimes we get PrEP, and we even get paid." So these brief examples, while alarming independently, must be held together. Jointly, the key tensions reflect extractive logics at the center of global health. Johanna Crane argues that global health science is the uncomfortable mix of preventable suffering and scientific productivity that paradoxically embodies and even benefits from the very inequalities it aspires to redress. So in listening to and learning from trans women, there is wisdom in their research mistrust, in mistrust of a system that privileges and replicates extractive data practices. As such, hesitancy, mistrust, loss to follow-up, poor enrollment, you name the synonyms, cannot be understood as a trait of trans women to be addressed solely through education about the research process, but as a justified response to systemic inequities replicated by and manifested through the extractive logics of research. Their mistrust is a learned community insight that underscores the inequities between communities, researchers, and the research enterprise. So there's another piece of this puzzle that must be underscored to understand the pervasiveness of these paradoxes in global health research conducted in Peru and beyond. This additional piece is the value-driving extractive data practices. Academic research begets more research, producing scientific knowledge as global currency. This is true for scientists and researchers like me, who realize that the ability to secure funding, progress through the ranks of academic promotion, depends on participating in this research economy. To illustrate what I mean by describing our field as a research economy, the image shows the process of data transformation and the value accrued at each stage, from the collection to the entrepreneurial opportunities presented in collection, management and analysis of data, to the knowledge dissemination, typically in the form of publications and conference talks, that yield scientific capital through acknowledgement and career advancement. As we know, manuscripts operate as the ultimate record keeper of a scholar's scientific reach. And they are essential to demonstrate expertise and acquire grants and serve as revenue-generating assets that indicate ownership and expertise. Jointly, these processes, individually and collectively, foster systems that maintain and sustain the HIV enterprise on a global scale. While this is presented linearly, this is far from true. These processes are messy, they're complicated, and they have differential gains. Here it is helpful to point to the reality that many US scientists have enhanced their own careers by being quote unquote trained in Peru, me included. And yet when speaking to Peruvian researchers about these professional relationships and the imbalance of power, they scoff and refer to this imbalance of power as normalized. It is what it is. This imbalance is systemic. Take, for example, ownership of knowledge dissemination. The path to establishing expertise is understood to primarily apply to investigators from the global north, namely the United States, and only the most senior Peruvian collaborators. For example, Juancito, a Peruvian project coordinator with more than a decade of experience with HIV research, a Peruvian medical degree, and a US master's degree in epidemiology described, publications don't really help me keep a job. They would be good, but I will never be a leader of HIV research in Peru. That role is reserved for US investigators. Power imbalances described by Juancito in knowledge dissemination are a symptom of greater systemic fissures. To disentangle notions of imbalance, it is important to describe how funding is distributed and operates. I want to provide a brief example from both the US context and the Canadian context. The US NIH funding awards include direct costs. So these are expenditures budgeted for scientific research and listed in the public domain, and indirect costs defined as expenditures related to facilities and administration. So let's just give like a very simple example. So if I were to be awarded $1 million grant, depending on what institution I was at in the United States, the institution charges indirect costs. So this doesn't come out of the $1 million pot. It's a percentage of that that comes from a different pot of money. So let me just give you an example of the range of indirect. So for example, Harvard's current indirect fund is 87%. 87% of $1 million grant stays at the institution for the administration of the grant. In many fields, this does make sense. So for lab scientists, bench scientists, there is extreme cost with the science. In my scenario, as we will see a little bit later on, it doesn't quite make as much sense. So Harvard's at 87%. I think Columbia is now at 61%. The University of California system, which is a public system, hovers around like 40 to 50%, depending on the school. NIH does not determine indirect costs. Rather, each US academic institution establishes their own fee, right? The range I just gave you. However, NIH does limit the number of indirect fees that a foreign institution can charge, and that is limited to 8%. So so this simple example illustrates two key points. First is the systemic imbalance between US-based and foreign sites with respect to funding allocation. While this relates to indirect, not direct costs, it's important to note that, at least in the case of Peruvian HIV studies, 8% indirects does not cover expenditures related to facilities and administration when the majority of the work takes place at the foreign site. So just to give you an example, I know this is probably against policy, but all of my Peruvian collaborators have my UT Torrid ID or whatever it's called, because institutionally, the charges to join the library journal systems are simply too expensive. So, and these are world-class institutions that house millions of dollars of research funds internationally. Okay, so the second point is that the structure of funding has created a context in which scientific research is an enterprise, not only for researchers, but also for academic institutions. And here's where I want to cue the point that I said earlier is we talk a lot about the political economy of research. We don't talk as much about the political economy of academia and how these two become entangled. So second, for a Canadian example, so while Canadian Institutes of Health Research does not cap indirects the way NIH does, systemically, there are limited pathways to pay and support international PIs and community leaders as central to intellectual contributions of research agendas. Perhaps some of you here today have solutions you can share. But for me, the central tension I'm dealing with is how to pay Peruvian PIs, both at academic institutions and at community organizations. So here's the thing. In Canada, the understanding is that academics are paid by the research institution. That's not the case everywhere, at least not the case in Peru. So what I've been told, and these are like from program officers to very bright colleagues. So these are some of the suggestions I've heard. Apply with the PI. And then once you get the money, remove the PI as PI, so then you can pay them. Or the loophole of getting institutional letters that attest that international PIs are not being compensated by the employer for the time spent on grant-related funding activities. So yes, there's a half solution, but this solution is only for some PIs at some academic institutions. For me, the larger take home is that the default mechanisms are not set up to support equitable collaboration. Indeed, the system isn't even designed to contemplate anything besides global North power. Okay, but I hear you all saying, but wait, wasn't this talk about learning from trans women, about the harms of extractive data practices in HIV science? Yes, 100%, like that is why we are here. And these lessons cannot be understood or learned without a recognition of these larger systems at play. So to begin to consider actionable improvements to HIV biomedical research, it is critical to draw attention to the multiple forms of power that underline the politics of HIV science, which impact all involved in the industry or the enterprise. The story of extractive data practices traded in a global economy is not unique to the contemporary HIV industry, but rather a key element of health research, which frequently leverages made vulnerable communities. This research is meant to serve as a living laboratory. The lessons and tensions that I am sharing today should not be understood as something that's happening over there in Peru or over there with trans women. Rather, my hope is that the three lessons presented today, so one, why more research and not more health, two, economies of research, and three, are we just guinea pigs, will resonate with many of you who are trying to do work day to day in the land of health equity to actively ameliorate the pervasive disparities that shape vulnerability to different health pathologies. And yet, when making these arguments, I'm often met with comments from colleagues who push back and advocate for more active allyship, suggesting that a possible way forward is better community relations, more robust community advisory boards, methods and design co-developed with community. 100%, totally for it. And yet this is not enough. The other part, which must go hand in hand, is the recognition of the greater systemic issues, namely the tenets of capitalism that are inextricably intermeshed with global HIV science and practice, namely the push for more data without the push for more health. While the imbalance of funding and indirect direct funds is a small piece of the puzzle, it is quite illustrative of inequities that are built in and replicated within the system. The call to action for us, for all of us here, is not as simple as to deal with the indirects. I wish it were. Rather, our work and responsibility as researchers lies in actively recognizing our role and the part we play in the perpetuation of extractive data and the benefits received. This is the first step in rectifying broken trust between community and researchers, and this is the base from which we must start to imagine, to build and sustain a more just HIV science. Okay, so what is the call to action? In the work to come, because yes, there is work to come, let's remember and remind each other that when we do not name capitalism, colonialism, racism, heteropatriarchy, and other intersecting modes of oppression, the possible harms of research are too easily ignored. Our call for equity and a more just imagining of HIV science, what it can and should be, cannot be divorced from an examination of the role that power and politics play in the perpetuation of extractive data practices. Whoops. Okay, so the two photos presented here highlight the strength, the power, and the ongoing solidarity enacted by trans and gender non-binary people in Peru. This is my reminder of who I am accountable to. So yes, let's push, let's fight, let's advocate. Let's join those brave enough to call for a disruption in health sciences. But in doing so, we need critical reflection, awareness of the role we as researchers play in the system and how the system is broken. It is only then that we can move towards accountability. So for the next generation, and unfortunately, the work gets carried on, to enact this change, we must underscore that health science is political. To listen to and learn from made vulnerable communities that we are accountable to, justice and solidarity must drive our praxis. This depends on authentic community relationships and co-learning. And this requires funding, not solely as peer recruiters or in a community advisory board capacity, but real money for, and to acknowledge the labor of grassroots organizations, the brilliance of community leaders, and dedication of global partners that make the research happen. And funding to support health, not data, necessitates bearing witness to the violences perpetuated by the system, to disrupt and to invite change. So hope for change is necessary, but in the wisdom of the late Paulo Freire, my hope alone is not enough. Rather, we need critical hope as a collective and iterative praxis. We need to take action by learning about and from the discomforts, the contradictions, and the violences of global health, to move towards reimagined possibilities. So, in an aim to stimulate reflection and critical hope, I ask you, why more data and not more health? Who benefits from all the data that's being collected? And who is responsible for addressing the oppressions that yield pervasive and growing health disparities? That's all for me. I just couldn't figure out the slide. So thank you all so much.
Thank you, Amaya.
Yeah.
A passionate, substantive perspective that is something quite different than what we usually hear in this room, and is definitely provocative and stimulating of thinking. I'm thinking of how this relates to my own research and the work that I do with Indigenous communities here and with queer and trans communities here related to tobacco. So thank you for casting light on that. Pam, are you there? Are you hearing? Are you ready to deliver your remarks?
Yes, Rob, can you hear me?
I can hear you. Can you hear Pam out there? Try again.
Hello. Hello. Hi, everyone.
Yeah, I don't know why, because let me just try something here. Okay. Oh, okay, I need somebody knows what you're doing. Thank you.
Yeah.
Is the output on the Zoom? Okay. Okay, hang on, bear with us here. One sec.
No worries.
Go into your system.
Video?
No,
This
mute,
one?
go to the arrow.
Mhm.
Okay, and do audio settings. And then we can go into, go to advanced. Oh, actually, look at
Here, the
who's on
speaker.
here. Yeah. Do it.
Let's do the
Is it
system.
yeah.
Okay, Pam, try now.
Hi, Rob. Is that better?
So then change
Thank
this.
you so much.
Change this
Okay,
one too as well.
change this one too.
Yeah. Save the system there.
Okay, Pam,
Okay.
go ahead. You have up to 5 minutes.
Okay.
And we're gonna put you on speaker view here. Okay, all set.
All right. All right. Hi, everyone. And I'm so sorry I couldn't be here in person, and I really appreciate you being able to accommodate me today, Rob. Wow, Amaya, thank you so much for your incredibly thought-provoking talk. I had so many things going off in my brain as you did your talk, as well as when I read your paper and looked through your slides earlier. Your in-depth qualitative work on the experiences of trans women really reflects the issues with biomedical research in so many marginalized communities across the world, particularly in the global south. And so much of the work that we do, it may not be biomedical, but regardless of the type of research we do, it really focuses or forces us to examine our own research practices and those of our institutions as well, regardless of whether it's biomedical or not. And as you presented, it's not just about what will forward science and benefit researchers and institutions, but what will benefit the community that's actually being researched. And I think this is very relevant to public health policy, which should be based on evidence, but your presentation really highlights questions about what knowledge is informing policy. So I think it is quite relevant. So I have a number of questions, and this isn't an area I've done a lot of work in, so bear with me, but you may not be able to answer all of these questions, but you can decide which ones you want to tackle. So first of all, in addition to our own self-reflection as researchers, I was, of course, wondering how we can play a role in changing things at a more systemic level, which made me think about what the barriers are to systemic change at the institutional and industry level, and what we can do to be part of these changes. How can we avoid what some scholars refer to as equity washing, where researchers and institutions add maybe superficial or name-only equity efforts, but they don't actually change the system? And related to that, my second question, and you did sort of address this already in the talk, and I think your answer will be it's not enough. But I wondered what your thoughts are about the role of data sovereignty frameworks that try to foster more equitable data practices, such as the First Nations Principles of Ownership, Control, Access, and Possession, or OCAP. There's the Declaration of Research Assessment, DORA, which I wasn't as familiar with. There's also the SPORE, the Strategy for Patient-Oriented Research, that's being used by funding agencies in Canada and elsewhere. And thinking, I mean, I have a little bit of experience with the SPORE approach, and it's easy to add, it's not very difficult to add or respond to the SPORE principles in a grant proposal, but it's challenging sometimes to actually make it happen on the ground when not all stakeholders may see the value. And relationship building does take so much time, but our research models don't often allow for that kind of community building. And I know you did say community building is not enough. Another question I had, I found your discussion, or sort of a thought, I found your discussion on the wisdom and mistrust to be so fascinating. As a qualitative researcher, I often think about the value of local or community knowledge and how it can contribute to a better understanding of whatever topic I happen to be studying. But I didn't really think about it in the context of systemic inequities within the research process itself, and the impact of that on the quality of the research as well. And I was also thinking that qualitative data is often disregarded as being of less value in biomedical research or sciences compared to the quantitative data. And government and funding agencies are often looking for stats on what's going to work. And it really, I don't think it values qualitative research as much. So I wondered what your qualitative research on the mistrust has been, how it's been received by the prep researchers that are conducting the clinical trials and can actually benefit from a more equitable process. And then finally, I was wondering what we do when our values and needs are misaligned with our funders or our government policies. And is there, or policy making, is there a role for policymakers to or public health practitioners or researchers to educate funders and government about the value of more equitable community partnerships? So I know that's a real hodgepodge of thoughts and questions, but I will leave that with you. Thank you so much for a brilliant talk.
That is, you know, Pam had like 3 days, I think, to think about this. So that is incredibly impressive. And our practice is generally to do the 2 discussants. So if you're able to hold your fire a little bit, we'll get Reagan to come up here and deliver her discussant remarks. Then you have an opportunity to respond to both.
Great.
Or we can go to the audience and you can respond after that. Pam, we're going to keep you up on the screen if that's okay with you. Okay.
And I will try my best not to overlap too much. So in your study, you spoke to how PrEP has spurred this like projectification of research, where a seemingly endless series of isolated short-term trials that aren't integrated into existing healthcare systems, even when interventions are proven to be effective. And that I think this is coupled with a plethora of evidence to suggest that research is not seen as meaningful by participants when research findings are not coupled with ways to apply those findings to community needs or the development of actionable outcomes. And that this gap can be seen as a form of exploitation in which is institutionally based researchers enter communities to extract information, building careers off community suffering, and do not provide communities with solutions or support in return. So I'm wondering how, and I know you spoke to this a bit, but how you think individuals, especially when working in global health settings and working overseas, can better ensure that their research is able to translate into action, and what you think the barriers to continuing research beyond data and into actionable tasks are. You in your study, women speak to this kind of weighing of options where women don't necessarily want to engage in studies, but given it's their only avenue to access care, it almost becomes a situation of health needs outweighing personal autonomy. And so from an ethical standpoint, I'm wondering, in working environments where research participation is fueled by access to life-saving care, what role do you feel that research ethic boards and ethic review boards need to play in shifting the dial? And what considerations you think that researchers need to take when engaging in work where there is this dichotomy? And I'm also wondering, the ability to engage in more participative research is often inhibited by a publish or perish attitude within academia, or by traditional ways of distributing funds, which you spoke to. So when speaking to the systemic barriers to producing research that actually impacts health, is there policies you feel could be implemented to ensure that adequate allocation of funds or adequate time spent on research is embedded within policy, instead of falling on the onus of researchers who choose to jump through hoops to ameliorate disparities in how research is facilitated? And finally, when research is participatory and meaningfully carried out, it can position itself in a unique position to positively impact policy by bridging communities and science to ensure balance of political, economic, and cultural priorities. In our public health policy course, we speak a lot about looking at like multiple streams framework and how windows of opportunity open. And I'm wondering if you think that research that involves folks as participants instead of subjects is better positioned to create windows of opportunity for policy change. And is there a potential for a strategic approach to global prevention research that could be utilized when communities are specifically seeking out action outcomes related to policy change?
Thank you, Reagan. I think Amaya's hand is tired from writing, and she's run out of room on her page to collect all of that. But I think you have enough material to go for another hour at least. So choose, and you can put things together to the best of your ability. Take your time. We have until 2 o'clock, so that's another half an hour. I know that the people in the audience here, and perhaps people online as well, will have additional questions. So it's in your hand.
Awesome, thanks, Pam. Thanks, Reagan.
Better if you
If I go over there. Okay. Here I am. Okay, so I'm happy to start answering this, but I would be much more keen to hear other folks' thoughts and how this might relate to some of your work. So let's see, where do we start? I guess one point of clarification is the work that you read and kind of the talk was based primarily on qualitative findings, but as a team, we are developing this in like a mixed methods way. So especially leveraging policy, we're starting to look at structural dimensions of stigma and how that influences care. So oftentimes, I hear this like quant-qual divide, and for those who are quant researchers in the room, you're not absolved, right? There's like lots that you can do in the critical quant space to kind of advance some of these notions. Okay, so Pam, you mentioned a point about Indigenous data sovereignty, and actually I'm going to send this to Rob afterwards. We're doing a workshop co-hosted with Edinburgh and Universidad Peruana Cayetano Heredia in Lima, looking at these issues of global data governance and sovereignty to kind of learn from processes. So that might be of interest to some folks. The thing is, so there's so much to learn from Indigenous data sovereignty, and thankfully we have experts in-house at DLSPH who can teach us about these processes. The thing is, it is still insufficient. So it's a step forward, but it's a step forward within these larger processes. So the questions that still need to be asked is it ownership of the data that holds benefit, or it's how the data are then being used and leveraged? And so I've had some of these. So on Friday was the National Dialogue of Indigenous Data Sovereignty that I had the privilege of attending. And these were the same things that came out, like 100% communities should be in charge of data, but does that really mean handing over a hard drive post-research when still the articles and the grants, like we can trouble that, like we can still think critically about that. And so it is a step forward, and we need to acknowledge that, and we need to learn, and we need to actively engage in these learnings. And we still need to continue to push to say, where are the limitations and where do we go from there? Another thing that I wanted to comment on, Reagan, from your comments was this issue of systemic barriers. Like, yes, publish or perish. And oh, by the way, you are all being socialized in. And even when you take my classes, right, the outcome evaluations are now prepare the proposal so that you can become independent scholars, now prepare the papers so that it's in publishable form. So it's about thinking through how you're being socialized as well. One of the question that you pose is my biggest Achilles heel, isn't like the right word, but it's one of the biggest things I'm dealing with. It's in the teaching and the replication of this. And I don't know. Because I am not an emancipatory scholar that I'm saying, let's burn the system to the ground. There are many brilliant people who are saying that. My position is to change the system from within, recognizing the oppressions of the system. The piece for me, though, is the training piece. I don't know. When I teach on sample size and design and intervention and, my bread and butter is cluster randomized trials, like, how do we get around these issues? I don't know. And, because the people we consider mentors are people we love and who love us, some of my mentors have said, it's okay not to have the solutions, but it's bringing the discussion forward. I understand how superficial and unfulfilling that sounds, but that is part of it. It's bringing forward these tensions so that we can start to work through it. But for me, your point about the training hit the nail on the head, because I can fight all day long against Tri-Council and NIH. I have zero problem doing that. And in fact, I'm happy to do that in public forums. But the accountability that I have towards students is a different one. And so part of my responsibility in this role is teaching you about the system, which I recognize replicates some of these inequalities. So I'm all ears, but it warrants that being underscored, that this talk is not a solution talk. It is what's to come and where we're at. Oh, there was a mention about health needs autonomy and REB. REB is the last of our worries. Like, there is like so much work that needs to be done before we even get to REB. And for me personally, I get frustrated with like the institutional barriers of that. Like, yes, like let's work towards changing REB. But before we get towards working to changing REB, let's talk about how we talk about key populations, made vulnerable communities, who's at risk. Let's think through how we talk about racialization and gender and sex. Like, that's the bigger work that's harder. policy change institutionally is process, right? Like we can get there, but we can't get there until we have a shared understanding of the values of what it really means to be at heightened vulnerability for health disparities. Okay, that was more pedestal than I wanted it to be. But I would be delighted to hear some questions, thoughts, perhaps how it's related to your work. Yes, please.
I'm sitting here, it was just I'm actually working on a project directly related to this, that I was so fascinating, it's from the perspective of food systems and transforming food systems away from how, especially on the global scale, so I'm looking at Latin America. And I'm seeing a lot of echoes there because the foundation of why they got started was in opposition to a Dutch NGO trying to come in and control the voice, and that political economy of academia and food knowledge is valuable, especially those people who are working in agriculture. I thought it was I was very much seeing the element there.
Great.
Hearing what you're saying, I was like actually internalizing and going right to the presentation of just linking in it. So I want to thank you.
I'm pumped it resonated. And the point that you made about like this social political history, like that's the big one, right? Like we talk about social determinants of health. We don't really talk about the history of how social determinants of health came to be in a post-Cold War era and the politics that informed the categories of social determinants of health. Like all of this stuff is political. And the point that you just gave is exactly that, like in all of our contexts. So in my context in Peru has been set up to be a prime site of HIV research because, oh, by the way, when HIV came to be, HIV was given to the US naval base to do the first surveillance studies of. So like, there's a reason why the research industry has been set up in such a way that it allows for this offshoring of data. Brazil is an excellent counterexample that when HIV came onto the scene, HIV was taken up as a project of democracy because it was coming out of a period of dictatorship. And so research systems didn't evolve the same way. But that takes long histories to like kind of understand and disentangle. And again, while superficial, it does need to make a plug for collaborative teams because one person alone cannot possibly know, all these intricacies. Yeah. Carmen Logie at Social Work wrote a beautiful commentary using critical hope as well. So if folks want to think through other scholars at Dalama who are using the concept.
I think and you touched on this a little bit, but sometimes we talk about kind of the role of policy on and highlight that, this work is really more research, but it actually results in more help. And so I'm wondering, do you think like our role as scholars, is it possible in that to develop more help, or does that kind of be a shift to being policy on where like it's complementary, or do you think that the scholars and development can take on that policy on the role of push for the help beyond research?
I think it's both, right? Like, and I also think that there's strength in numbers. So there's individual level of accountabilities that links back to like individual values. But then again, with the strength in numbers approach, like one person cannot simply do all the work. So how do you make those strategic alliances? When do you choose to disseminate data first to key stakeholders and second to peer review publications? There's like a lot of these day-to-day choices that do actually have significance. So I hear the word entrepreneur a lot right now in health sciences. And for one of you who've taken my theory class, I cannot think about entrepreneurship without a think of capitalism. So like, great, we're entrepreneurs, but for whom and for why? Like my grants as entrepreneur benefit the institution. So like, we really got to think through some of these complicated roles, and especially with the increase of private-public partnerships, like my research in Peru with PrEP could not be done without Gilead. The medication is simply too expensive. And I will be the first to warn against public-private partnerships. But like, these things are too complicated to say, oh, bad global North research are doing global health. Like, it's not the case, right? And so it's the fact that we do need to look at this systemically.
want to jump in on that point and elaborate a bit, because it strikes me that, the tri-council, particularly CIHR, but also sure, lots of areas, have, made steps, maybe they're baby steps. But they have made steps to ensure that research is, relevant, is engaging both communities and policymakers, right? So, in a lot of the grants, you've got to have that policy person, and as part of it. What it doesn't have, though, is any, type of accountability verify the results of it. You need to demonstrate actually to the funder that you've done something in order to bring about some, policy change. So I'm just thinking about how, the institutions are set up and systemic, in a way that, doesn't, value, the transfer of knowledge into policy. And that's something that I'm wondering what you.
Well, it's coming down the pipeline, right? So like there's data management protocols that we are all going to be accountable to. Like I think the Tri-Council one is being released within a month. NIH's is out. NHS's is coming out later this spring, where all data that is funded by public money goes into a larger repository, right? And so I think on face value, it's like, okay, public money, public data. But wait, like, wait a minute. Like, what does it mean? Like, who is the steward of this data? Who actually benefits from these data in a public repository? Because it's all about the tools for access. And so again, it's about like digging a little bit deeper and starting to think through like, okay, like I get the point of open access data, but wait, to use this data, don't you kind of need a PhD or access to some kind of analytics to make it useful? Like, that's not open access data. And so when we think about that, and I know that this isn't exactly where you were going, but when we think about that, like those kind of policy moves come with big money. And so it does warrant a reflection of like, okay, data is important. We're going to store it in open access sources, but what would it look like if, in a matrix kind of way, we took the other pill and instead of investing in data infrastructures, we invested in community infrastructures. And so instead of having to write a data management protocol and data transfer agreement, you actually have to write a protocol on equitable engagement with community and get community to sign off on a data management plan. Lots of work, I get it, right? Like we know, lots of work, but it's about how we value these things differently. And so, there are steps and there's interesting steps, but again, these steps are political. And as big data is easier to mine and to make more valuable, like it reflects the ways policies are engaging.
Are there any?
I think it's a little bit more like centralized to your study specifically and not as overarching, but I know that like when we think about open research communities, something about like that side where like Bandu put together these like the research management stuff for what communities expect for people coming in. And I'm wondering if you saw anything similar in your work in the communities that you were in where feminine rights or any organizations were kind of working to put together their expectations for what research is going to provide to when they are approaching this community.
Yes, the question was making the comparison that over-researched communities here often make demands of researchers to, the nothing about us without us kind of calls that they have to get community buy-in before doing the research. And if I've seen something similar in Peru, did I do that? Okay, different context. So Peru in general is much more active with social movements and social organization, like riots, tear gassing, like it's a much more violent kind of upheaval of a society. So yes, and especially the feminist movement in Peru is super active. There was a beautiful New York Times article covering the feminist movement in Peru a few years ago, if anyone's interested. our thing isn't as much with research as much as with social movements. So we do have to make, especially if there's any sort of randomization in our trials, we do have to get community buy-in based on national edict. So, but when we do our community presentations, I've seen several trials be stopped because community says, and it's not only stopped in the administration, but it's simply stopped in the recruitment. Like word gets out and people say no. This is complicated when community needs the medications. So in my example, especially with trans women, violence, oppressions, and social marginalization is such that the power of the social movement isn't that of broader cis feminist movements. May they join forces in the future? Hopefully. But in my case, there's less pushback because of PrEP. And the understanding that not only PrEP, but treatment. And so, by the way, I'm talking about oral PrEP now, but now we're in the land of injectable and 2-on-1 intermittent PrEP and injectable treatment. And so these technologies save lives, are expensive, so it goes back to the point of autonomy and coercion and what it means to do the research in these settings.
Great, I'm not seeing any, there's a hand back there, and then if anybody on Zoom wants to speak, after this question, you can just unmute and pose your question. Go ahead.
Let me in here with the doctor, because I know it's.
I'll repeat, you just have to speak loudly.
Okay, so. Possible. So going back to what you were saying about the issues of getting grant funding for collaborators in Peru, and how there are these like certain structures where people in Canada or in the US are well compensated, and kind of there's extravagant practices of like, you get the data and we're benefiting, but not people on the ground necessarily are benefiting directly from the data collected. But how do you argue to the government or taxpayers that like, of course, it's Canadian tax dollars going towards research that should be technically benefiting Canadians? How would one make the argument that this research in Peru, this is exactly what, this is a clear reason why this money should be put towards another purpose? I would expect that would be like conversation that's additional on navigation.
Okay, so let me try to repeat that. So the question is, given that these funds are coming from public funds from Canada and the US, how do you make the argument to taxpayers that the majority of the funds and benefits should leave country to this? Okay. Yeah, I mean, for me, it's a bit of a chicken and the egg question. Like, then why fund global health research, right? So like, if we're saying global health research benefits the funders, like, let's call it as such. And we're not, right? Like, that's not part of the game. Like, there's more and more conversations about decolonizing global health, but those conversations really center on like authorship diversity or like partnership parity in the, but like, we're not really talking about like, where does all the money go? I agree. It's a hard argument. And like every time, so I'm funded by Canada and NIH has a clause that every time I put in a grant, I have to say specifically how this benefits the US. And it's always this, repeat sentence of these findings may have impact for Latinx communities in the US. Maybe, like, I don't know, like,
but CIHR, and CIHR says at least that global research is legitimate research for community.
They say it.
Conversation with Stephen Hawking, the director of the population health. He said absolutely, and he's fighting to make sure that it's the case. He is
So saying it and then the actionable items that show it systemically. So like, so here's the thing. So I'm American coming to Canada. There's been a lot of learnings. Like, honestly, one of the biggest learnings has been around Indigenous data sovereignty, which I'm very grateful for. The other learning is, as we all know, Americans are quite American-centric. I thought NIH was the end-all be-all. And coming here, one of the other things about CIHR that like really, while insufficient, the sex gender paragraph is quite an advance compared to NIH. And so like NIH is currently going through the fights and the policy to disentangle sex and gender. So like, I mean, this feels like didn't we do this 30 years ago? But no. And so it's active, and it's similar with the global health space. So like Canada does have many lessons to be learned with regards to how we even speak of global health. Like everything in the NIH system is foreign site, foreign investigator, et cetera. So like, it's not to say that there aren't lessons. Part of this provocation is to say we can't let down our guard, because even though that there's advances, wow, is there still room to grow?
Okay, is there anybody on Zoom who wants to unmute and ask a question? Excuse me. Once, twice, 3 times? Okay, it seems that, we are out of questions, surprisingly. So, it leaves me to thank, all 3 speakers and to ask any of you with any final comments. No. So, yes, thank you. Go ahead.
A lot of the presentation was like really interesting perspective on how like who are serving and what's the purpose of research. And I think as like a young person enter academia a lot of time, it's like, well, sometimes you get halfway to a product to be like, well, this is actually answer the question I was pursuing, is this serve the community I was going to serve? But you're on a low level power, so it's not how will it even detail that impact. And so I'm grateful that it's happening in conversation in our of not everybody that we're considering these things, so I have to tap into how that, you know, when you're starting to reveal the agency to ask those questions or that's just it's like happening in Canadian research a lot of time too, where I mean I always have one from like school food from the perspective like a lot of time the questions being asked are like more data for what? No action, more data for where, for me to localize and target explicitly against what evidence we have. So it's like a very interesting diagram of practically really what would motivate policy action. I think not conclude with this not evidence. It's like political environments, it's the social realistic political will, state entrepreneurs and flashpoint moment of policy center changes. But I'm just like, I guess we just I don't really have a question, just really enjoy this conversation for how it makes you think about how to challenge the systems and you know those that research gets, because it's not only the money we're starting with. Really looking at entering to see how I guess stakeholders that you're serving, so policy change that you want to see. I just love that of it, yeah, like I felt piece that it kind of want to serve and
Thanks for saying that. I just want to make a few pushes on it. So when I say politics, it's big P politics beyond structural determinants, which I think sometimes like, you know, we may not be as comfortable with, like how like, for example, misogyny is a form of politics and, you know, continues on. The other thing, your point about like power holding, what's fascinating is I've been giving this talk for about 6 months and it like needs to be retired. It needs to become a paper. And I can't tell you, almost every time I get it, if there's an older academic or a more senior academic in the audience, I get the comment of, you should probably wait till post tenure to move this forward. And so like, every stage has a power dynamic, right? And so like, if we wait till the next stage, like this shit's never gonna happen. Like I just became an assistant professor and I'm tired. You know, like no, but like seriously. But so like if I wait till I'm tenured.
yeah, but what is the point of waiting though?
Well, I mean, because of the system, right? Like we all see it too much. Like I don't know how many of you are on Twitter, but like we all see the tenure debacles. And we all see how especially racialized women are so like, you know, there is something there also about like navigating power. And again, I think the issue is strength in numbers.
Like everybody waits after tenure, we're still waiting until tenure until infinity and beyond.
And tenure's going away. Like let's, you know, anyway, the point is to say, like, we can't wait. Like these conversations need to be happening now.
Yeah, and you do think like the social dynamic, I guess, for example, sometimes it does get a question of like, well, do I do it? Do I take the academic, do the jump skills? There's a lot of NGOs, there's a lot of that, and for those guys, yeah, it's always like it's happened in the route for this movement, and to be supported by it, sure, like not to downplay the evidence, being out there, but just sometimes it's again, to think like, is this the right system for this type of change?
But academia holds power. like, sorry, Rob, I know we have to end, but like,
No, I want to respond as well.
go for it.
Okay, so then I just, I'm hearing your frustration. That academics are doing all this research and it's not always making a difference. And I think you even said, well, it's not gonna make a difference, evidence is only one piece of the pie. And so, it's frustrating. If I really want to make policy change, I can do something else. So yes and no, right? So if that's the message you've heard from the training that we've been doing here, no, not completely. Yeah, research is one piece, but it is one piece. And it's one piece that doesn't always have immediate implications, but you as a researcher have a job. And I've said this, I'm sorry for being a bit passionate about it, but this is what I believe in, is how I deal a little bit with the dilemma, right? Which is that you have got to take on the role of advocacy, and not just go and apply for the next grant, but actually to do work with the findings that you have. And, it's every opportunity to try and make a difference. Is it always going to succeed? No. But if we didn't have that evidence, okay, sometimes the evidence can sit here for years and years and years. But when the policy agenda, as we talked about, when the windows open up, it's going to be looked at and be part of what is being delivered.
I agree. And there's different roles. And so like you do you. Academia is not for you. You take on your fight in whatever role you want to go. And so for me, like the team I'm fortunate enough to work with, we have journalists, academics, community advocacy groups, and so it's a net, right? But there is power in academia and there's power being housed at U of T, and none of us can forget that. So I'm going to Lima on Sunday because amidst all of this upheaval, the Ministry of Health doesn't know what the hell to do with Venezuelan migrants. And so part of my research program is on Venezuelan migrants. And why are they want to talk to someone from the global north? Well, because we know those dynamics, but you better believe that I'm capitalizing on that opportunity. And we're not only going to talk about migration, but we're also going to talk about HIV with trans women in Peru. But, we also have to recognize this is a provocation, and in part it's polemical, right? Because I'm trying to get us thinking, but it's not a good bad, right? There are active fights racialized data in Canada. We don't even know what the hell's going on because we're not even collecting the data, right? So that's part of the fight, but it's how we collect the data and in learning from the other harms that have been ongoing with the collection of the data.
You certainly provoked, and I think that was your intention. So thanks for the provocation. Thanks for coming. Thank you, Pam, for joining us at the last minute and doing amazing work in preparing. Thank you, Reagan, for really, really thoughtful remarks. And thanks for all those participating today. We'll have one more round next month. Thank you very much.